Welcome all for today's class. So today another high-level topic we are going to discuss, that is radiotherapy in gynecological oncology. Okay, so this is a very frequently asked question or semi-long question or short note either in the MS paper or university examination or the DNB examination. Okay, not only that, certain topics are important from viva discussion point of view, because your viva may go on CA cervix or some other cancer, and there may be discussion on radiotherapy. So basic concepts about the radiotherapy are must. Okay, so when you read about any short note, or when you are writing about any short note, please ensure that you have the outline ready. Okay, for the answer you need to have the outline. You can keep the paper and pen ready, and you can note down certain important things. Okay, so if you get such kind of question, radiotherapy in gynecology, under which heading you are going to discuss, you will write about the introduction. Some radiation physics you need to mention, that means the sources of radiation, units, photon interactions, etc. Then radiation biology we will write, that is the mechanism of action, how they do the DNA damage. Then types of radiotherapy, in which you will mention about the EBRT, okay, external beam radiotherapy, brachytherapy. Clinical applications in the gynecological oncology we are going to mention. Complications of radiotherapy, and you need to enable certain newer techniques like IMRT, that is intensive modulated radiotherapy and all that. Okay, so let's see what exactly we are going to write here. Okay, so radiotherapy is the use of ionizing radiation to destroy the malignant cells while minimizing damage to the normal tissue. So what we are going to do is to destroy the malignant cells with the help of ionizing radiation, but there should be minimal damage to the normal tissue. And we need to know the radiobiology of normal tissue. So when the normal tissue is exposed to this radiation, what kind of effects you get? Okay, so when the normal tissue is exposed, there is going to be loss of mature functional cells. Okay, and this is mainly because of the apoptosis, that is the programmed cell death, which happens within 24 hours. Okay, so what is the effect on the normal tissue? There is a apoptosis and physiological death which happens within 24 hours. This happens in the mature functional cells. Okay, then there is going to be loss of reproductive capacity. Okay, so stem cells lose ability to divide, and severity will depend upon the total radiation dose, duration of treatment, and radiosensitivity of the tissue. Okay, so functional cells will undergo apoptosis and stem cells will lose the ability to divide. Okay, then we will talk about the measurement of the radiation. How the radiation is measured? It is measured with unit, that is amount of radiation absorbed per kg tissue. Okay, that is measured in gray. Okay, so 1 gray equal to 1 joule per kg equal to 100 rads. Okay, and another is a centigrade. So 1 centigrade is equal to 1 rad. Okay, so these are the units which you should know and which you should write. And for paper part 1 of MRCG, these are the MCQ questions also. Then another topic from the radiation physics is a oxygen enhancement ratio, that is OER. Okay, so oxygen enhancement ratio, if the tissue has got a good oxygen content, okay, or tissue is well oxygenated, this radiation will kill the cells, so the effect is better. But if the tissue is hypoxic, then there is a less effect of the radiation. So what is this OER? OER is the ratio of radiation dose required to produce the same cell kill under a hypoxic condition versus oxygenated conditions. Okay, so OER you need to write, that is the ratio of radiation dose which is required to produce the same cell kill under hypoxic condition versus oxygenated conditions. Okay, so hypoxic cells normally require 2 to 3 times higher dose. Hypoxic tumors are relatively radio resistant. Okay, so this OER concept you should understand and you should mention when you are asked about this. Second is the inverse square law. This is also very frequently asked viva question. What is inverse square law? Okay, so the amount of radiation at one particular point is inversely proportional to the distance, square of the distance from the radiation source. Okay, so dose of radiation at one particular point is inversely proportional to the square of the distance from the radiation source. Okay, so what is the importance? There is a rapid fall in the dose away from the source. As you go away from the source, there is going to be the rapid fall in the dose, and this is what is the basis for the brachytherapy. You keep the source close to the tumor. Okay, so it protects the surrounding normal tissue. Then what are the biological effects of radiation? What is the mechanism of action of this radiation? There is a direct action of the radiation by causing DNA damage. It is more common with the particulate radiation. Okay, but the most important is the indirect action. Okay, the commonest action of radiation is the radiation acts on the water and it creates the free radical, that is hydroxyl ions will be produced, and these hydroxyl ions will cause the DNA damage and mitotic cell death. Okay, so this flow chart you should remember how they are acting. Radiation is acting, it is acting through the hydroxyl radicals. Okay, then what are the cellular effects? There will be DNA damage, gene mutation, mitotic arrest, loss of reproductive capacity, and cell death. So these are the cellular effects which are seen. Then we will mention about the radiosensitivity. So it is the ability of the tumor cells to respond to the radiation that depends upon the tissue oxygenation, cell cycle, tumor type, tumor volume, etc. And which factors will increase the radiosensitivity? We have already mentioned about the OER. So well oxygenated tissue, better is the radiosensitivity. Rapidly dividing cells, higher is the radiosensitivity. So most sensitive cells are if the cell is in M phase or G2 phase, they are more sensitive, and the least sensitive will be cells in the late S phase. Okay, that is the synthesis phase. Then if you have a small tumor volume, it has got a better oxygenation, fewer hypoxic cells, so it will be more sensitive. The highly radiosensitive tumors are the dysgerminomas. Okay, so what are the types of ionizing radiation? Basically, there are two types of ionizing radiations: electromagnetic radiations, that is the photons. Okay, so which are either X-rays or gamma rays. So you have two types. One is electromagnetic radiation or the photons, and second is a particulate radiation. In electromagnetic radiation, you have the X-rays and gamma rays, and in a particulate radiation, you have the electrons, that is the beta rays, then protons and neutrons, out of which electrons are the routinely used in the radiotherapy. Okay, so among the particulate radiation, electrons are the more routinely used. So you should write about the types of radiation also. Two types of radiation, that is electromagnetic radiation and the particulate radiation. In electromagnetic radiation, you have X-rays and gamma rays. In particulate radiation, mainly the electrons which are used in the radiotherapy. Now we will talk about the electromagnetic radiation. So electromagnetic radiation, two types we have already mentioned, gamma rays and X-rays. Okay, now what is the difference between these? So this gamma rays, what is the source? They are produced inside the atomic nucleus, while X-rays are produced outside the nucleus. Okay, so gamma rays are produced inside the atomic nucleus, X-rays are produced outside the nucleus. So gamma rays are produced by the radioactive decay, and X-rays are produced electrically by specialized machines. Okay, so gamma rays are produced by radioactive decay. Sources are cobalt 60, iridium 192, etc. And X-rays are produced outside the nucleus and generated by some specific machines, that is LINAC. Okay, linear accelerator. This is the commonly used nowadays. Okay, LINAC. Okay, and there is a Betatron. So there are certain interactions of the photon with the tissue. So we have seen this electromagnetic radiation or the photon, when they are interacting with the tissue. So what are the three interactions? There are three interactions which happen. One is a photoelectric effect, second is a Compton scattering, and third is a pair production. Okay, so if you remember all three, well and good. Otherwise, even if you remember Compton scattering, that is more than sufficient, because that is most important in the radiotherapy. Okay, so when the photon interacts with the tissue, it produces important effect, that is the Compton scattering. Okay, so basically if you look at this, so this is the incident photon. So and these are the electrons. Okay, so these are various electrons in various orbits. So what happens, this incident photon, when it strikes with the electron, this gives the energy to the electron, and there is a increase in the energy of the electron. The electron will become the fast electron. Okay, and this incident photon will not disappear, but it will be present as a scattered photon. Okay, so this is called as Compton scattering effect. Okay, so this is the effect which is used in the radiotherapy. Then what are the examples of the isotopes which are used in radiation? You have cesium-137, which is used for intracavitary brachytherapy. You have cobalt-60, which is used for both brachytherapy as well as EBRT, that is external beam radiotherapy. Then iridium 192, that is for interstitial implant. Okay, iodine 125 for permanent implant. Radium 226 is not used nowadays, and phosphorus 32. Remember, P for P. Peritoneal therapy is given with the help of phosphorus 32. Okay, iridium is for interstitial, cobalt is for both, and cesium 137 is for intracavitary brachytherapy. Okay, so these are the few examples which you should mention. Then the techniques of radiotherapy, we know that there are two basic techniques. One is a brachytherapy, another is a teletherapy or EBRT. So in brachytherapy, that is the internal radiotherapy. So here the radioactive source is placed within or close to the tumor. Okay, so there are certain subtypes, that is the intracavitary or interstitial. Okay, so in intracavitary, the examples are uterine tandem or vaginal ovoids or colpostats. Okay, so it is mainly used for carcinoma of cervix, endometrial cancer, etc. So if you see this CS cervix treatment, here there is a tandem and these are the two ovoids. Okay, so when we discuss about the radiotherapy for CS cervix, there are certain points which you should know, that is the point A and point B. These are also the viva questions. Okay, what is the location of point B, what is the location of the point A, and which is the reference point for prescription of the radiation. Okay, which point should receive the maximum dose. So these are a few questions which you should know, and the concept of point A and point B. Okay, so point A is the most important point. What is the location of point A? Point A is located 2 centimeter above the external os and 2 centimeter lateral to the midline. Okay, and this point A is the anatomical location of the crossing of the uterine artery and the ureter. Okay, and point B is located 3 centimeter lateral to the point A. Okay, so point B is 5 centimeter from the midline or 3 centimeter lateral to the point A. Point A position is 2 centimeter above the external os and 2 centimeter lateral to the midline. Okay, so these are the 2 points. So point A is located 2 centimeter superior to the external cervical os or the flange of the intrauterine tandem and 2 centimeter lateral to the central uterine canal. What is the anatomical significance of point A? Point A represents the region where the uterine artery or crosses the ureter, that is the paracervical tissue. Area of the paracervix or the parametrium where cervical cancer commonly spreads. So this is the area where the cervical cancer commonly spreads. Okay, so that is why this particular tissue, this particular point should receive maximum dose. And that is the primary reference point for the dose prescription. So which point is used as a reference point for dose prescription? It is a point A. Okay, so maximum radiation dose is prescribed to point A and it determines the tumor control in carcinoma cervix. Then coming to the point B. Point B is located 3 centimeter lateral to point A, that is the 5 centimeter lateral to the midline at the same horizontal level as point A. What is the anatomical significance? This point B is gives the precise location of the obturator lymph node and the pelvic side wall tissues. Okay, and what is the clinical importance? It estimates the radiation dose received by the pelvic lymph nodes. Okay, this point B is not used for prescribing the primary tumor dose. So primary tumor dose is decided by the point A. Okay, so this is just the diagrammatically, you have the central tandem in the uterine cavity, and if this is the external os, then you go 2 centimeter superior to the external os and 2 centimeter lateral to the central midline, you will get point A. Okay, so this is what is the location of point A. And from the point A, at the same level, if you go 3 centimeter laterally, you will get the point B. So point B is the location of the obturator lymph node. Okay, so this is what you should mention. If you are writing about the radiotherapy for CS cervix, or note on the radiotherapy in gynecology as such. Okay, so this is what is point A and point B. Okay, so point A is used for calculation of the tumor dose. Point B is the pelvic lymph node dose. Then used in Manchester intracavitary brachytherapy system for carcinoma of cervix. Point A is the most important reference point in the cervical cancer brachytherapy. Okay. So if you are asked in the viva, point A is situated 2 centimeters superior and 2 centimeters lateral to the cervical canal and represents the paracervical region where the uterine artery crosses the ureter. Point B lies 3 centimeters lateral to the point A, 5 centimeters from the midline, and represents the pelvic lymph node region. Okay. So this is what we have discussed about the brachytherapy. Now, that is the intracavitary, we have seen brachytherapy. Then another type is the interstitial brachytherapy, where the radioactive needles or the wires or seeds, they are placed inside the tissue. The sources which are used are the iridium 192, cesium 137, cobalt 60, and this is used for small vaginal tumor. Okay. So surface application is done for skin lesions. Then you have intraperitoneal therapy, that is phosphorus 32. So these are all types of brachytherapy. Okay. Then what is the technique for giving this brachytherapy? It is the after loading technique. Okay. Remember, the technique is a after loading technique. Now, what is the principle of after loading technique? Here, the applicator is inserted first. So first is the applicator. So you have applicator and you have the radiation source, out of which you introduce first the applicator, confirm the position of the applicator with the help of X-ray, then you insert the radioactive source later on. Okay. So you have to protect the health worker also, and you have to protect the normal tissue also. Okay. So what you do, first applicator will be inserted, then position will be confirmed by the X-ray, and then the radioactive source will be inserted. So this insertion of the radioactive source is done by two ways. One is a manual method and another is a remote after loading. This remote after loading method is better because it protects the health workers from the radiation. Okay. So these are the steps. First, you insert the applicator. You confirm the position of the applicator with the help of X-ray. Then you insert the radioactive source. This radioactive source can be inserted by two ways. One is a manual after loading technique, and second is a remote after loading technique. So this is what is the after loading technique, in which the applicator is inserted first, position is confirmed, and then the radioactive source is introduced. Okay. So this is very important. Okay. And after this, the source will be withdrawn. Okay. Then what is the dose of the radiotherapy? There are two types of doses. One is a low dose radiotherapy and second is a high dose radiotherapy. When you give low dose radiotherapy, that is around 50 to 100 centigrade per hour, it requires admission because the longer duration will be required. But when you give high dose radiotherapy, that is 100 centigrade per minute, it becomes an OPD procedure, and this is most commonly used. Okay. High dose radiation is the most commonly used. And this is the figure which talks about the isodose distribution curve with intracavitary irradiation. So when you give intracavitary irradiation, these are the curves, isodose curves. Okay. Distribution curve, isodose distribution curve. Okay. So when you have the radiation source in the center, the radiation dose received at each of these particular points on this line will be same. The radiation dose on this particular line or on all points will be same. Okay. And as you go away from the source, there is a drastic reduction in the dose of the radiation. Okay. That is the inverse square law. Okay. So isodose distribution curve, and this is the pear-shaped curve because the source has got a radiation source is a multiple in nature. Okay, so if it would have been a single source, then it would have been a circular. But here it is a pear-shaped isodose distribution curve you get. And what are the advantages of brachytherapy? It gives high local tumor dose, then sharp fall of radiation, then there is a minimal normal tissue injury and excellent local control, because then you can give this brachytherapy close to the tumor. That is why high dose to the local tumor, sharp fall of radiation, minimal normal tissue injury, and excellent local control. These are the advantages of brachytherapy. What are the disadvantages? And this is not suitable for large tumor, and radiation exposure to the staff can happen unless you do the remote loading. Okay, so remote loading, what we have seen here, this is the remote loading, okay, done with the help of machine. This is the manual loading. Okay, so if you do the remote loading, there will be less exposure to the staff. Okay, then another type of radiotherapy is the external beam radiotherapy. This radiation is derived from a source outside the body, that is teletherapy, and most common source is a LINAC, that is the linear accelerator. Another is a cobalt 60. Okay, so what are the uses? It is used for primary tumor treatment, parametrium, pelvic lymph nodes, and it is also useful for the large tumor volume. Okay, while brachytherapy is not suitable there. Okay, then what are the goals? There should be uniform radiation. Okay, then there should be no hot spots, no cold spots, and accurate tumor localization. So when you give EBRT or teletherapy, hot spots are the areas where you get a maximum radiation. Cold spots will be where there is a no radiation. So there should not be such spots. There should be uniform radiation. So this should be the goal when you give the EBRT. Okay, and there should be accurate tumor localization. Then coming to the radioisotope installation. Okay, it is used in ovarian carcinoma. Okay, gold 198, phosphorus 32, small peritoneal deposits, pleural deposits, where the radioisotope is instilled into the tissue. Okay, then you have the palliative radiotherapy. The aim of palliative radiotherapy is a rapid symptom relief from bleeding, pain, bone meds. In these cases, you can give palliative radiotherapy. It uses the lowest effective dose. Okay, another important concept in the radiotherapy is the fractionation. Okay, so you should understand this concept of fractionation. Here the total radiation dose is divided into small daily doses. Okay, so you calculate the total dose and you divide this total dose into small daily dose. Okay, so you will have a standard schedule that will be once daily or 5 days per week. Okay, or 180 to 220 centigrade per fraction. Okay, so example is a 40 gray in 20 fractions over 4 weeks is given. Okay, so that is how the dose is distributed. Okay, so that is called as fractionation. So total radiation dose is divided into small daily doses. Okay, so what are the advantages of fractionation when by dividing this total dose into small fractions? It allows the normal tissue repair. Then tumor accumulates irreversible DNA damage, and it reduces the complications. We have seen when you give the radiation, the normal tissue as well as the tumor tissue will be exposed to the radiation. But when you do the fractionation, what happens? Today you give the dose, then next dose will be given after 24 hours. During these 24 hours, normal tissue will recover. Okay, there will be a repair mechanism which are happening into the normal tissue. So this fractionation permits the tissue repair in the normal tissue. But what happens? Here in tumor cells, these tissue repair mechanisms are damaged. Okay, so they do not repair in by next day. So there is an accumulation of the irreversible DNA damage. So yesterday the tissue was damaged by the radiation. Today there will be further addition to that particular DNA damage. So this is tumor will accumulate the irreversible DNA damage because of fractionation, while normal tissue there will be recovery, and this is what reduces the complication. So that is the importance of fractionation. This concept also in radiation you should be able to mention. Now let's come to the adverse effects or the early radiation reactions. So, okay, so in early radiation reactions, normally in general, there is anorexia, nausea, vomiting, fever, fatigue. GIT, you will have enteritis, colitis, diarrhea, proctitis. So these are the inflammatory changes which are happening into the various body systems. Okay, urinary, there will be cystitis, pyelitis, hematuria. In hematological, there will be leukopenia, thrombocytopenia, anemia. Then skin, there will be moist desquamation, peeling of the skin. Okay, then there are certain late radiation complications. This is mainly because of the fibrosis. First, there is an inflammation, then there is a fibrosis. Okay, there will be vaginal stenosis, radiation proctitis, intestinal obstruction, intestinal perforation, rectal bleeding, malabsorption syndrome, osteoporosis, pathological fracture, and there can be fistula such as vagicovaginal fistula, rectovaginal fistula, and there can be ovarian failure leading to premature menopause. So these are the early and the late complications of the radiotherapy. Now something about the newer technique or the advanced radiotherapy technique, in which you have a 3D conformal radiotherapy, that is 3D CRT, that uses the CT scan, MRI, PET. The advantage is that beam conforms to tumor and less normal tissue exposure. Okay, then another is the intensity modulated radiotherapy, that is the IMRT. Okay, computer controlled beam intensity is there. Advantage is that precise tumor targeting, reduce bowel and bladder toxicity, and treats irregular tumor. Okay. Then you have a tomotherapy where CT guided radiotherapy is given. Then you have cone beam CT. Okay. Here image guided radiotherapy is given. Then you have stereotactic radiotherapy. Here advantage is that very high precision and it gives high dose delivery. Okay. Then you have gamma knife, precise stereotactic radiation. Okay. Then there are certain radio potentiators or hypoxic cell sensitizers that will increase the radio sensitivity. Which are these agents? You have chemotherapeutic agents and some other agents. In chemotherapeutic agents, you have cisplatin, paclitaxel, then gemcitabine, and doxorubicin. These are the radio sensitizers. Okay. The others are misonidazole, metronidazole, TNF, and interferon, and acyclovir. So these are the radiosensitizers. Then hyperthermia, that also acts as a direct anti-tumor therapy, and it is also a radiosensitizer. Okay. Now treatment field for the carcinoma of cervix. When you give the radiation for carcinoma of cervix, what is the superior boundary? What is the inferior boundary? Okay, so superior border is between L4 and L5. Inferior border is inferior margin of the obturator foramina, and lateral border is 1 centimeter beyond the bony pelvis. Okay, and lead compensator will protect the central pelvis after the brachytherapy. So when you give EBRT for carcinoma of cervix, so brachytherapy, if it is already given, then the lead compensators are there, because when you give the external beam radiation to the tissue, central part has already received from the brachytherapy. So there comes the role of the lead compensators. They will protect the central pelvis which has already received the brachytherapy. Because it has received the brachytherapy, so now there is no need for the dose to that area. So that will be protected, and the rest of the area will be given the appropriate dose of the radiotherapy. Okay, so that is the role of the lead compensator. Okay, then comes the role of radiotherapy in epithelial ovarian cancer. Generally, ovarian cancer, it is a surgical treatment. Routine post-operative radiotherapy is not recommended. Then after surgery, we give most of the time chemotherapy. So routinely not recommended, but may be used for peritoneal metastasis, lymph node metastasis, or palliation of pelvic or bone recurrence. Chemotherapy remains the standard treatment. Okay. Then what are the contraindications for radiotherapy? There acute PID, chronic PID, pelvic kidney, large fibroid uterus, procedentia, ovarian tumor, genital fistula, young woman, then vaginal stenosis, adenocarcinoma or adenosquamous carcinoma, where the surgery is preferred. So these are the contraindications to the radiotherapy. So from viva point of view, certain things which you should remember: OER, that is oxygen enhancement ratio. So what is oxygen enhancement ratio? It is the ratio of radiation dose required under hypoxic condition compared with the oxygenated conditions for the same degree of cell kill. Okay, so how much is the amount of radiation which is required to have the same tumor cell kill under hypoxic condition versus oxygenated conditions. Okay, so higher OER equal to greater radio resistance of hypoxic cells. Okay, so oxygen increases the effectiveness of radiotherapy by enhancing DNA damage. Okay, so OER equal to dose in hypoxia divided by dose in oxygenated tissue. Okay, then you may be asked about the inverse square law. So radiation dose is inversely proportional to the square of the distance from the source. This is the inverse square law. This also we have seen. So difference between the EBRT and brachytherapy. So brachytherapy, where the source is inside or near the tumor, gives high local dose. There is a sharp dose fall off and best for cervical cancer. While EBRT, where the source is outside the body, treats large field, uniform dose distribution is there, and it treats the tumor plus lymph node plus parametry. Okay, so certain things which you should remember. Most important phenomena is a Compton scattering. Okay, this is what we have seen. When the incident photon strikes the electron, it gives the photon gives the energy to the electron. The electron will have the high speed, but the photon will serve as a scattered photon. Okay, the photon will not disappear. Okay, the standard unit of observed dose is a gray. Then most common free radical causing DNA damage mechanism is a hydroxyl radical. Okay, so free radical mechanism is the most common. Then most radiosensitive cell cycle phase is the M phase followed by the G2 phase. Then most radiosensitive gynecological malignancy is a dysgerminoma. Most commonly used external beam machine is a LINAC. Okay, common concurrent chemoradiation drug is a cisplatin. This finishes the topic. Thank you.